Let's move on and talk about a patient population that's very common in the pre-hospital and in-hospital setting for that matter, the morbidly obese patient. Starting with a patient vignette, let's talk about this 44-year-old female. She's found with an altered level of consciousness. Her mother called 911 with concern that she may have overdosed on her medications, but she's not sure which. Her eyes are closed. She's got incomprehensible mumble. She does withdraw from pain. Her respirations are snoring. Her breathing is slow and shallow. Her lung sounds are clear, though, and they're equal bilaterally. Skin is pink, warm, and dry. Vital signs show soft blood pressure, mild tachycardia. Her respiratory rate is 8. Her SpO2 is only 88% on room air in the supine position. The remainder of her exam shows that she's atraumatic. Her pupils are 4 millimeters and reactive to light. So thinking about different causes of overdoses, of course, we think about opioid overdoses, but we don't have the pinpoint pupils. It doesn't really quite fit there. By all means, trying some Narcan is quite reasonable. The overdose that comes to mind next is more of a sedative hypnotic, something like a benzodiazepine. Regardless, this patient offers many clinical challenges. If we're not able to improve her ventilation and oxygenation with BLS maneuvers, if we're not allowed to quickly reverse her condition, we may have to consider intubating for airway protection. This is a big clinical challenge, but it's a common one. About 80% of US adults are overweight or obese. They have a 4-fold risk of all medical complications compared to the non-obese. A large percent of the population is morbidly obese, which gives us our greatest challenge. From a respiratory standpoint, a big challenge is that these patients can be hypoxic at baseline. They often have sleep apnea and a perfusion ventilation mismatch. They have essentially a restrictive lung pattern due to their heavy body weight and their body habitus. They actually have a 50% decrease in their functional reserve capacity, which means that they desaturate much quicker than their slender counterparts. Their work of breathing can be 30 to 400 times greater than someone of a normal body habitus. These patients are very high risk for desaturation. This photo may look familiar to you. It basically is comparing the desaturation rates in different patient populations. Now, this was desaturation for patients who received succinylcholine. And essentially, the take-home for this was, regardless of the patient, if you give succinylcholine and you're not able to intubate, you're still responsible to ventilate the patient and oxygenate them before the paralytic wears off. So regardless of what paralytic you give, the patient will desaturate before that wears off completely if you don't manage their airway. So again, the adult male or female who's a normal body habitus, who's not critically ill, can actually go for quite a while, especially with some sort of passive oxygenation. But patients can go, 6 minutes before they start to desaturate in some cases. But let's face it, most of our patients are at least moderately ill, and they're going to desaturate much quicker. Kids, which we're going to talk about in another class, desaturate quickly even if they are healthy. And our obese patients, even the ones who aren't critically ill, will desaturate in a minute or two. And then you add critical illness or any sort of disease process to the mix, they're going to desaturate very quickly. Let's move on to some cardiovascular challenges. These patients have an increase in their extravascular volume. They have an increase in cardiac output. Their heart is having to work harder to circulate that extra fluid. They have an increase in their left ventricular and end-diastolic pressure. So the heart is working much harder. So left ventricular hypertrophy is very common in this population for that reason. The total volume of blood is increased, but relatively, it's actually decreased by 1/3 because most of it goes intravascularly. Renally, these patients have increased renal blood flow as well. They have an increased GFR. And again, they're more likely to suffer from kidney disease due to the history and comorbidities. When we think about structural changes in the obese, we think about the increased chest wall weight, so the weight that the muscles of her respiration have to push again, increase facial girth, so large mass around the outside of the neck, but also internally. We have redundant tissues that make it difficult to ventilate these patients, which is why they often suffer from sleep apnea. They have a smaller pharyngeal space due to the fat disposition, and increased neck circumference in general. These patients often have an increased mountain potty score. So it's worthwhile to take a sneak peek before you paralyze this patient. Check out their mountain potty so you know what you can get an idea what to expect and make adjustments based on that. So the approach to the patient, we're going to use our mnemonics. We're going to think about difficult laryngoscopy. We're going to think about our ability and challenges to bagging these patients. Difficulty with supraglottic devices. This is due to a few factors. High airway pressures because of the body habitus and the weight, and also difficulty getting a seal due to the redundant tissues. These patients may be difficult to crite just due to inability to feel those landmarks and find midline. We may have to go through many layers of tissue before we can find the tissues we need. So they desaturate rapidly, they're difficult to ventilate and intubate, and all of my backup plans are also difficult. So one of the most common difficult patient populations is one of the most difficult by far. So let's think about some techniques that make us successful. One, positioning, right? Elevate the head of the bed. Get them on the gurney whenever possible. Ramp them up 45 degrees if I can. This will really help with pre-oxygenation. Even if you need to lay them back a little bit to be able to intubate them in the best position, get them upright for pre-oxygenate them, and also keep them up if you can. This can help prevent your desaturation. Just get the weight off their chest. Remember, our medication dosing is a little bit different in the morbidly obese. For our neuromuscular blocking agents, we're going to go total body weight. For our induction agents, we're going to think lean body weight. So here's an example of aligning the airway axis in the obese patient, much like we do in any other patient population. We still want to make sure that we get ear to sternal notch alignment. We want to make sure that we align the oral pharyngeal axis and the laryngeal axis so that we have the best view. But we also want to get the patient sitting up, ideally on a gurney, and get the mass off of them so we can pre-oxygenate them. All right, so how about the bait between sux and rocuronium for the obese patient? There's been some OR studies that actually showed that rocuronium had some extra safe apnea time compared to succinylcholine. This hasn't parsed out in ER studies, and it hasn't been clearly studied in the pre-hospital setting. But they did notice that patients who were obese had an extra 46 seconds of apnea time. And when I have a patient that I know will rapidly desaturate, this might be a factor. So I may consider rocuronium for one more reason in this population. The theory here is that succinylcholine uses up O2 while it depolarizes. The fasciculations happen, and as the cells that pump the ATP use the ATP to pump the potassium back into the cell, that might use additional oxygen compared to rocuronium. Types of body weight. So when we talk about medications, you'll hear things like lean body weight, ideal body weight, total body weight. So ideal body weight is actually based on the patient's height and gender alone. The lean or the total body weight is what do they actually weigh today, whereas the lean body weight, for our purposes, is what we're going to use as the skinny person on the inside. Now, there are some formulas for these and more complicated ways to calculate this. But if you have a morbidly obese patient who's 6 foot tall, you can ballpark what the skinny person on the inside would be. So medication dosing. When I think about my induction agents or my sedatives, I'm going to go the sort of lean or ideal body weight. So what I think the patient's healthy weight would be, a ballpark of that. Some of you may have charts in the back of your medic units for different medications that give you these based on height and gender. That can be helpful in this setting as well. But remember that your paralytics, rock or sux, both of them should be total body weight for these patients. This is twofold. One, circulatory volume in theory, but really the reason that we want total body weight dosing on these patients is because they're already going to be a difficult airway. So we really want to err on the side of getting them completely paralyzed. These medications can't be overdosed with few exceptions. You don't have enough of either of these medications in the back of your rig to cause any harm to the patient. So get them fully paralyzed and increase your first pass success.